Your brain is your body's control center, shaping how you think, feel, and move. When something goes wrong, it can affect everything. Welcome to Your Brain, Your Health, a podcast from St. Luke's Neurosciences. We'll explore conditions that impact the brain, spine, and nervous system, and how they connect to your overall well-being so you can stay informed and take charge of your health. Welcome to Your Brain, Your Health, a podcast from St. Luke's Neurosciences. Thank you for joining us on today's episode, Where Did My Memory Go? Understanding Transient Global Amnesia. I'm Dr. Eric Eustace, an emergency physician with St. Luke's University Health Network.
And I'm Dr. Daniel Ackerman, Section Chief of Neurology and Director of Stroke and Vascular Neurology at St. Luke's. Now, many people have recently learned about Transient Global Amnesia, also known as TGA, when veteran journalist Katie Couric shared her experience with the diagnosis. Sudden memory loss can be extremely alarming, and it can be mistaken for a stroke, it can be mistaken for a seizure, and we wanted to take this opportunity to explain to people what's really happening, especially because TGA is a temporary condition that resolves on its own, and recovery is usually excellent. So joining us for today's conversation is Dr. Brian Hanrahan. He is a neurologist with St. Luke's University Health Network and an expert in epilepsy and seizure disorders. Brian, thank you so much for joining us today.
Thank you very much for having me.
So, Brian, tell us a little bit first, though, like what is TGA and how do people experience it?
Yeah, I mean, the nice thing about this disease is that the words of the diagnosis give it away, right? It's a transient illness. It goes away after a very short amount of time, typically 24 hours. The amnestic part is pretty profound and global, as in there's the inability to form any new memories. So very often people forget why they are in a location, why they are performing maybe something going on around them, why they are wearing the clothes they are wearing. As shocking it is for the patient, it's also very alarming for friends and family or anyone who's around them.
Absolutely. Now, it was described that Katie was repeatedly asking questions. She couldn't remember the answers from moments earlier. Is that typical, or what does this actually look like for caregivers?
Usually you'll see someone performing an act or in the middle of doing something and kind of forgetting why they're performing that task. So just for insight, actually, I've had two family members myself that have had TGA.
Whoa.
My understanding is TGA includes sort of two different kinds of memory loss. So there's a little bit of what we would call retrograde amnesia, meaning you can't remember certain recent events. So retrograde meaning past, you can't remember some of the recent stuff that's happened. And then anterograde or moving forward amnesia, meaning you're not forming new memories. The people who are experiencing this often can still do a lot of different things. People have been known to drive, to get around, to do things. They're not just stuck standing in one place.
Yeah, they'll be able to ride a bike and do arithmetic. But during the transient episode, you're right in the fact that they're not forming new memories. So if you told them a new number to remember or a new fact during that episode, they're not going to retain that new memory. So if you gave them breakfast, and then 2 hours later, if they asked, are we going to eat this morning? That's very common during the episode of TGA.
Can I ask, how long does it normally last? Is it 24 hours? Is it 12? In Katie's, description, I know it was a little bit shorter, but can you describe kind of what the average time frame of this can occur?
Usually there's a near complete or complete recovery within 24 hours. And usually the most severe symptoms are typically the first several hours. And then there's a slow progressive improvement where, maybe after, being told where they are for the fourth time, they will finally remember why they're in the hospital. So it does seem like there is a peak of severity at the very beginning or the onset of symptoms, and then there's a slow recovery over the following hours, over a day.
Katie's recovery was, of course, very reassuring. In my experience of working with patients with this, although they recover fully up to the way they were before the event, they typically don't gain or retain any memories during the event, right? So there's always that little black hole that those memories don't come back because they were never there in the first place. They
were never formed in the first place.
We were awake, we were behaving, but we weren't making memories. Although what is left in its wake is sometimes a profound anxiety about the event and what happened.
The fear of what happened during that course.
Sure. Has that been the experience that you've seen with your patients as well, and even with members of your family? Is that?
Yeah, it's definitely an anxiety-ridden experience where there is that Yeah, that was crazy, or that was scary. The fact that you just, lost a day of your life, and there's no insight as to why it happened or anything like that. And hopefully the things that we're going to be talking about more later during this podcast will kind of give some more light about the fear of what to be worried about, or lack thereof, if you or a family member ever had one of these experiences.
When do you call 911? When should I come into the emergency department?
As a physician, taking a step back, if a family member ever asks me, should I bring them to the hospital, my first question is, if you ever have that concern,
Yeah.
you should probably do it. We see acute neurological events all the time, and there is that time sensitivity issue. The last thing we want is someone to kind of just like, oh, well, maybe I'll sleep it off, and all of a sudden you realize there was some type of intervention that we could have provided to prevent an irreversible brain injury. The hard part is that TGA can look very similar to a lot of other neurological disorders that require urgent and rapid management that, a common person may not know the difference of what TGA looks like versus a stroke or something like that. So it's really important to be evaluated in that high care environment that you work in to be able to differentiate whether this is something that is a stroke-related pathology or a TGA episode.
The symptoms of TGA can be, as you point out, completely similar to the symptoms of a stroke or the symptoms of a seizure. The manifestation of those things can be similar, and we wouldn't expect a patient or a family member at home, even a family member who's a healthcare provider at home, to try and differentiate between those things. We would typically say that, treat it like one of those emergencies. If it turns out to be TGA, that's great because it has such a good prognosis for recovery, but we don't know that at the start.
Yeah. All time is the only one that really helps us figure that out.
At this point, what do we think about what some of those potential causes are, and who are the people who tend to be at risk for this?
I think the hard thing is that transient global amnesia can look like a lot of different things. So a lot of things may be part of that differential and can only be proven or disproven depending on the testing. So someone who has a focal impaired aware seizure may have some confusional symptoms after the fact, and you may not be able to prove that association unless you got an EEG and you show that there was some dysfunction in the temporal lobe. Same thing would be true for an ischemic stroke, where there could be injury to the brain. You would need an MRI to evaluate that. And even if the symptoms looked like TGA, if you have a clear structural injury in the brain, then it can't be that. That's an ischemic stroke. When you really do all of the workup for any clear ideologies that we can easily assess for, and they all are unremarkable, you kind of get to the point where you're more convinced that this is a transient global amnesia episode. There's a lot of theories out there, Dr. Ackerman. You could probably give some more insight into that as well, including migraine aura, as well as seizure and stroke, which we've talked about. I believe there's also a theory about like vascular outflow of the brain.
We know that memory is sort of this distributed function in the brain, but there's still a memory center, if you will, and that's a part of the brain that we call the hippocampus. Does it have to do with the way blood is draining from that area? Normally, interruption in blood coming into the area causes a stroke, that causes damage. But if it's just trouble with the blood flowing out, could it cause some congestion? We know that this tends to happen in folks that are, I think, above age 50 or 60.
Yeah, typically in the adult
kind
age.
Kind of adult and middle age-ish range. And so, not that it can't happen in younger patients, but when you think about, all right, what is true about us in middle age that's not true for most folks in our teenage years and 20 years, it's easy to think about this as a blood flow thing, but we're not quite certain of that yet.
I think one of the interesting things is they haven't really found any clear smoking gun. If you have this, the risk is very high that you're going to have it. There's no lifestyle modifications to recommend, in your adult life outside of what you would recommend any 40 or 50-year-old, right? I mean, eat better, sleep good, a boring life.
We've been doing this podcast now, and what I've realized is there's not one single silver bullet to fix your brain or to prevent your brain from having pathology to it. It's let's live healthy.
Unless you're a werewolf.
Unless you're a werewolf.
Then it
prevents everything from you.
And there is a true silver bullet in that scenario.
Yeah. Are there certain triggers, or are there common things that seem to happen leading into one of these episodes, or is it always just out of the blue, no predictability?
I'd say maybe roughly half of people do report some type of triggering event, and it could be something that usually is like physically demanding on the body. So someone who does a very vigorous labor in their backyard, moving a bunch of rocks, or someone did a polar bear plunge or some excessive exercise routine for one reason or another, like a few hours before an episode, something like this can trigger it. And it's, again, not really clear why. It's just something that we've noticed regarding an association. So when we do evaluate these patients in the emergency room, when we're trying to figure out, is this TGA or something else, we definitely do like to ask, was there any, how was the last 24 hours? What have you been up to? And if someone did report some type of very physically demanding thing on their body, it helps us point more towards that direction.
You talked a little bit about some of the testing or things that you're looking for instead of TGA. So when somebody comes into the emergency department, what can they expect? I mean, we've talked a little bit about how you work up stroke and such, but what are some of those tests that will be performed to eliminate the possibility of other things going on?
I mean, one of the things about being a doctor that I talk about when I work with my medical students or residents is that you got to think in two ways. One is, what do you not want to miss? And what is the most likely? And if you can answer both of those questions, you can guide your treatment appropriately. So what do you not want to miss when you're evaluating someone with TGA? The real answer is ischemic stroke. So they're going to go down that whole ischemic stroke pathway. And that includes getting a CT of your brain, looking at the blood vessels in your brain, making sure everything is open and clear, and then eventually probably going to get an MRI of your brain as well, because if there was a tumor, if there was a stroke, if there was a injury that's causing seizures, you're going to be able to find that most likely with an MRI.
And what about the workup from a seizure standpoint? Since seizure and migraine are the other two big things that TGA can be mistaken for. So how do we incorporate some of that?
Very often you'll get at least a 30-minute EEG to add to it. We have no diagnostic test for migraine. But very often, because when someone does experience a seizure, they can be very confused afterwards. That can look amnestic-like. A lot of people sometimes have a hard time differentiating between the two. So an EEG can help us evaluate that possibility as well.
And just so if people don't know what an EEG is, can you just explain what an EEG is?
So an electroencephalogram, I think about it as a EKG for the brain. So most people in the world have gotten an EKG or seen someone that get the electrodes placed on their chest where they look at the heart rhythms. It's really the same kind of concept, but instead of the electrodes on your heart, we do the electrodes on the brain. So we place around 20 plus electrodes on the brain, and we kind of just look at how your brain communicates with itself to make sure everything is interacting appropriately.
So EEG, CAT scan, some of those other tests that you would get to kind of rule out other things going on, you can expect that if you go to the emergency department.
Absolutely.
Okay.
It's not to say when we're doing these extremely sensitive tests that everything will be perfectly normal. No one looks good under a microscope. No brain looks good under a microscope. Well, yours probably does, but for the rest of us, no brain looks good under a microscope. But without finding evidence of stroke or seizure, one of the things that does seem to persist, like we talked about earlier, is that hole in the memory. Mm-hmm. For people who recover, but they can remember bits and pieces. They remember being confused or having trouble with. They remember having trouble with their memory. That is not really consistent with TGA. Brian, to your knowledge, does TGA put people at risk for future memory loss? We've talked about dementia several times on this episode. Is this a harbinger of dementia to come?
I don't believe there's any association with neurodegenerative disorders like Alzheimer's disease and TGA. The outcome for this disease is actually one of the best ones I have as a neurologist. So I actually like making this diagnosis compared to all the other ones we could possibly find in an evaluation like this. There is a slight increased risk of having it again in the future, but it's so small that realistically, I'm just reassuring the family, reassuring the patient. I actually don't think I have in my 6 years being at St. Luke's seen a recurrent episode of transient global amnesia. There's episodes or there's reports of it, but it's extremely rare.
I've seen it once or twice. It is unusual. I agree with you. I've never seen anything that's told me, oh yeah, this means that there's some bad memory problem to come. Which anytime we start talking about memory confusion, the alarms start going off.
Yeah.
But
it's an exciting diagnosis to make because the outcome is so good compared to the other
right.
things. Right.
Compared to telling someone that they've had a stroke or that they've had a seizure and are going to be at risk for future seizures.
And need
or
medication
something.
in the long term and things like that, which fortunately for this disease, there is no evidence or no treatment recommendations after the fact. They don't say you need a baby aspirin or a lot of the other treatments that typically are used for secondary stroke prevention. So very often, the follow-up in these patients I'll see in the clinic, and it's kind of like, you're doing great. All right, good. Come back if something else happens to you, because the odds of it happening are very, very low. Yeah.
Just to wrap up, what's one thing that you think our audience would want to know regarding TGA?
While we're going to be talking to you guys about TGA today, it's something that I wouldn't trust anyone to diagnose outside of an emergency room. So if there is any concern for this acute confusional state, even if it's more just short-term memory, if there's really if there's any change in behavior, time is brain, and we really would want to make sure that
time is brain.
Exactly. Yeah. Dr. Ackerman paid me extra to say that today.
I feel good now.
Yeah. Make sure that you do get evaluated, and hopefully it is TGA, and that would be great. Again, because of the outcome and everything like that, it'll be a great story to share because there's no secondary ramification from it. But just to be aware that it exists, and it could be one of the outcomes when being evaluated for an acute stroke or something else.
Absolutely. So that brings us to the end of today's episode of Your Brain, Your Health. Thanks for joining us as we discussed transient global amnesia. Remember, this is a condition that can be extremely frightening in the moment, but as we talked about, it thankfully is temporary. It resolves completely. Overall, in terms of neurologic and scary things that can happen, at least this has a really happy ending to it.
Yep, memory loss should always be taken seriously, especially in the acute setting, so make sure you go to your local emergency department or contact your physician. And thank you for being with us today, Brian. If you'd like to learn more about St. Luke's Neurosciences and all the services we offer, visit sluhn.org.